Good afternoon and welcome. Thank you for joining Lung Cancer Canada's Policy Forum on treatment access and drug approval processes. I'm Dr. Stephanie Snow, a medical oncologist at the QE2 Health Sciences Centre in Halifax. I also have the privilege of serving as the immediate past president of Lung Cancer Canada and as a long-standing member of our medical advisory committee, working alongside an extraordinary network of clinicians, researchers, advocates, and people with lived experience to advance timely, equitable lung cancer care across Canada. Before we begin, I would like to acknowledge that the work of Lung Cancer Canada takes place on the traditional lands of many Indigenous nations, including the Mi'kmaq, the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. These lands are now home to diverse First Nations, Inuit, and Métis communities. This acknowledgement serves as a reminder of the need to ensure lung health resources and diagnostic innovations are accessible to all Canadians, especially Indigenous communities who continue to face systematic disparities in healthcare access and outcomes. Today's forum is part of Lung Cancer Canada's Policy Forum series, now in its second year, and it was designed to advance our 5 advocacy and policy priorities. This is session 2 of 3 in our 2025 program entitled Bridging the Gap: Precision Medicine in Lung Cancer Diagnosis and Treatment. Our lens this year is time to patient, how we shorten the path from evidence to equitable access. In session 1, we examined diagnostic and biomarker bottlenecks. Today we shift to the next barrier, treatment access. We'll look at where time is lost, from regulatory review and HTA to pricing, funding decisions, and interprovincial implementation, including take-home cancer drugs. We'll explore solutions, more harmonized pathways, aligned clinical algorithms, time-limited or conditional funding, value-based agreements, and better use of real-world evidence. And we will identify practical actions to reduce delays, improve consistency across provinces, and ensure patients fully benefit from precision medicine. As context, our Medical Advisory Committee is highly active in working with Canada's Drug Agency through clinician submissions. Today's dialogue will help inform that work. Thank you to our diverse participants. Together, let's move from challenges to clear implementable steps that improve outcomes and survival for all Canadians living with lung cancer. To open our session, I'm delighted to welcome Dr. David Stewart, Professor of Medicine and former Head of Medical Oncology at the Ottawa Hospital. Trained at MD Anderson, Dr. Stewart has authored over 340 peer-reviewed papers and has been a leading voice on how clinical research regulation and funding pathways can unintentionally delay patient access. He literally wrote the book, a short primer on why cancer still sucks, to educate and advocate on this subject. Today, he'll set the stage on where time is lost in approval and funding, and what targeted regulatory and policy changes can close the gap from innovation to patient access. Dr. Stewart, over to you.
Okay, first of all, I'd like to thank you for inviting me to take part today. These are my disclosures. And we recently reviewed 27 papers with statistically significant overall survival improvements published between 2000 and 2015. And what we found that was a median of 0.3 life years gained with each of these studies, which doesn't sound very much, but that's about 4 months per medication. And then we counted up the number of people dying of these malignancies worldwide and calculated that for every one of these drugs, there's an average of about 80,000 life years lost per year of delay in approval of the drug, or 1 life year lost for every 7 minutes delay for each of these drugs. And it took an average of 8 years for drug approval in the 1960s from drug discovery. It now takes an average of about 12.9 years. And for these studies that we reviewed, it was an average of about 12 years from drug discovery until approval. And so if you did when we did the math, we found there was an average of 1 million life years lost between the time of drug discovery and drug approval. And then we have the other problem in Canada that after the drug is approved, it then takes about 1.5 years from drug approval until the drug is actually publicly funded. And this is substantially longer than other members of the OECD. And so this translates into thousands of life years lost in Canada because of these delays in approval and funding. So what about the impact of speed for individual patients? So we recently published a paper where we did what was called population survival kinetics to look at the impact of delays in initiating treatment for individual patients. And what we found is that per week of delay in starting treatment with a metastatic non-small cell lung cancer, about 4% of remaining patients die each week that goes by without us getting treatment started. And if we look at one individual study, so this was the control arm, the best supportive care arm of one study, where 10% of patients died within 2 weeks of being randomized. And these were patients that had to be healthy enough to be randomized to a cisplatin-based combination chemotherapy. And if we look at further out on the curve, these patients are in a quadruple black diamond ski jump type approach that they just keep rapidly dying if treatment is not initiated. And this trial was similar to other trials that were included in the review, so there was nothing outstanding about this one. This is what you get with best supportive care or placebo in non-small cell lung cancer. On the other hand, if one takes the best platinum-based combination chemotherapy that's currently available, one immediately shifts the patients from this quadruple black diamond ski jump slope onto the intermediate slope. And then if people have a PD-L1 expression of greater than 90%, and one treats them with cemiplimab or pembrolizumab, then one actually translates them onto the bunny slope. And if we look overall at what happens, so that the hazard ratio for the platinum-based chemotherapy versus best supportive care is 0.24, meaning that we decrease the risk of dying each time point by about 76%. And if we look at the cemiplimab or pembrolizumab in patients with high PD-L1 expression, the hazard ratio is 0.09, meaning that we reduce the probability of dying at any one point by about 91%. So far too many Canadians are dying because of delayed approval and funding of effective new drugs. As far as what to do about this, again, it's in the book here. I can't go through all the different things that we need to do to fix this, but you can get a copy of the book online through Amazon Books, or you can email me and I'd be happy to send you a free PDF copy of the book for your personal use to fill you in on some of the things that can be done to fix this. The second issue that I'll discuss today is our problem with our gold standard. Our gold standard metric for defining drug efficacy, overall survival statistical significance, which is highly unreliable and misleading, and this causes problems. So our choice of gold standards markedly impacts our perspective. So, for example, in 1650, Archbishop James Ussher used the Bible as a gold standard and counted up the number of generations from creation to calculate that the earth was about 6,000 years old. On the other hand, if your preferred gold standard happens to be the rate of radioactive decay of different compounds, then the estimate of the date of the age of the Earth is about 4.5 billion years. So your perspective will markedly differ depending on the gold standard that you choose. And overall survival statistical significance is considered by many to be the gold standard for drug efficacy. And I completely agree that improvement in overall survival duration is very, very important. But overall survival statistical significance does not adequately reflect true improvements in overall survival, with too many false negatives and questionable positives. So I personally do not feel that it should be our gold standard, and this has major implications for how we decide to fund drugs and other things like that. So to assess this further, we analyzed 266 clinical trials of systemic therapies in advanced solid tumors published between 2007 and 2019. And we calculated the progression-free survival and overall survival half-lives. Half-lives are time to progression or death of half the remaining patients. And these are very, very similar to medians, but they're more reliable than medians because medians can be distorted by deviations in survival curves at their midpoint. And the one thing that that showed was that overall survival statistical significance, with it, there's a high rate of questionable positives. For among these 266 trials, there were 61 trials with a statistically significant overall survival gain. But of these 61 trials, for 10 of them, or 16%, the survival gain was less than 2 months. The rate of false negatives is even far more important. And as far as what creates the false negatives, first is what's called beta error. So this is a baked-in assessment that will permit 10 to 20% false negatives just based on the statistical testing alone. So the drug is effective, but it does not achieve statistical significance. And then we've got the problem of post-progression survival. By post-progression survival, if we have a drug, for example, that prolongs progression-free survival from 3 months to 6 months, the hazard ratio will be 0.5. But then if the patients in both arms of the study live an additional 18 months, then the hazard ratio for overall survival becomes 0.88. And there's only a very low probability that would be statistically significant. So a high proportion of trials with long overall survival gains fail to achieve overall survival statistical significance because of this. So the trials that we looked at, for those with an overall survival gain of 6 months or greater, fewer than half of them did the overall survival gain achieve statistical significance. Similarly, with a gain of 9 months or more, barely half of them did achieve statistical significance. And with a survival gain of 12 months or more, more than 1/3 failed to achieve statistical significance. And so some people would say, well, this is because the apparent gain in overall survival was just due to chance, and the statistics show it was not real. But in fact, what it was because of long post-progression survival. So that for the clinical trials with a survival gain of 6 months or more, the post-progression survival was significantly longer for those that did not achieve significance than for those that did. Same for studies with overall survival gains of 9 months or more that did versus did not achieve statistical significance. And the same with survival gains of 12 months or more for those that did or did not achieve statistical significance. And then the next problem is crossover. So crossover is people on the control arm being crossed over to the new drug. And drugs that are particularly effective, there's more likely to be a high rate of crossover because the oncologists know the drug is probably effective, patients know that the drug is probably effective, so they go on the control arm. They will want to go on the experimental arm if their tumor is progressing. And so here we just show that the progression-free survival gain is significantly longer in studies with high crossover than with low crossover. It's not high because of the high crossover, but rather the high crossover is there because the drug is more effective. But despite that, the probability of overall survival statistical significance is substantially lower when it should be much higher. So crossover also decreases the ability of progression-free survival gains to predict overall survival gains by increasing the overall survival rate false negatives. So we looked at, we showed that for studies with progression-free survival gains of 1.5 months or more, that there's a high probability that those would have an overall survival gain of 2 months or more. And many of them, it was much higher than that. And the positive predictive value for overall, if there was no crossover, then 95% of the time, if the progression-free survival gain was greater than 1.5 months, then the overall survival gain would be greater than 2 months. But if with crossover greater than 20%, it was much lower than that, not because progression-free survival became unreliable, but because the overall survival gain became unreliable. There are also different groups that have tried to define value of drugs using some of these statistics, and they're all problematic. For example, by the ASCO value framework, if a new drug increased overall survival by 1 week, from 1 week to 2 weeks, this would get top points. It would get 64 out of 64. Whereas if it increased overall survival from 5 years to 6 years, if it increased by 1 year, it would fail. It would only get to a score of 16 out of 64. And if it increased progression-free survival from 10 years to 20 years, it would barely pass. And at the same time, it did not at all consider the impact of crossover. Similarly, with the ESMO magnitude of clinical benefit score, it's also problematic. So here, a drug that increased overall survival by 3 months, from 1 month to 4 months, would score top marks with a grade 4 out of 4. But if it increased survival from 3 years to 4 years, by 1 year, it would fail. As would a drug that increased progression-free survival from 2 years to 3 years, it also would fail. And at the same time, they would not consider the impact of crossover. And also, they would only consider the overall survival if it was statistically significant. So if you had a drug that increased survival from 10 years to 20 years, but because of beta error, it failed to achieve statistical significance, they would toss that drug out as being ineffective. So in summary, as an indicator of true overall survival benefit, our gold standards of overall survival statistical significance and relative and absolute overall survival gains as measured in clinical trials are unreliable and misleading. And these are used by funding agencies to decide which drugs should be funded or not. And what we have found in extensive analyses is that the size of a statistically significant progression-free survival half-life gain is more reliable as a predictor of true overall survival gains, as outlined in our publications here. Thank you.
Thank you, Dr. Stewart. That was really interesting. Take us through those statistics and showing how our timelines do compare to those of other countries, which we all know translates into real-world access for our patients. Building on that systems perspective, now let's turn to the front line. I'm really pleased to welcome Dr. Sehdev. He's a medical oncologist and assistant professor at the Ottawa Hospital Cancer Center, and he focuses there on breast and skin cancers, and he previously led the breast cancer disease site. He's a graduate of the University of Ottawa with oncology training at the University of Toronto in Princess Margaret. And after that, Dr. Sandeep spent 25 years at William Osler Health System. He's the co-founder of a really exciting new group called the Cancer Clinician Advocacy Forum, which I think he's going to tell us more about. And he advises several national patient organizations. What Sandy will do now is he's going to connect system level delays to real patient care and show how coordinated clinician advocacy can influence regulatory and funding decisions to speed access and to improve outcomes. Welcome, Dr. Sehdev.
Yeah, thank you very much. So I think I have control of the slides, right? Let's see. Yes, so my theme really is coordination of advocacy efforts. Dr. Stewart has outlined tremendously the data side of things. When we kind of launched our group a while ago, I carefully looked around like a landscape review. Is there a need for this kind of group? Because everyone's doing great work in the individual disease site groups, but I think there is, and I'll show you evidence that we've been very well received so far. By coordinating our efforts and taking a strategic approach to messaging as opposed to individual data sets for individual cancers, we've been able to emphasize key principles that are barriers to access in our system right now. These are my disclosures. I learned from Dr. Stewart to always emphasize that the vast majority of my income comes from the government of Ontario, who pays me not to give stuff I want to give. I'll review our advocacy experiences and discuss some of the barriers and how we've approached them, challenges to implementation, and where our kind of group fits in, and how it might optimistically synergize with your individual groups like LCC or now Breast Cancer Canada. Well, we have an urgent need, as David has emphasized. So many patients will even pass away between lines of therapy in any cancer. They're not captured in clinical trial data very well. Our drug access systems are paralyzed. Despite the rigor of our process and how complex they are, we're still paying more per capita for cancer drugs than other European colleagues that are doing it better and faster. The delays are unacceptable. There is burnout from clinicians having to deal with these problems, and many young people are actually kind of giving up on trying. One big problem we have is clinicians are exhausted. Specialists in internal medicine spend 18.5 million hours a year in Canada doing paperwork, most of it unnecessary. And we all take that home with us. We actually document in Ottawa our pajama time. The computer nanny checks how many hours we're wasting on the computer at night and gets mad at us if we spend too much time. So our group is really trying to be a ragtag fleet of people together where we can coalesce behind common sense messages and maybe have one or two people lead an individual initiative and then pile on with the weight of our combined voices together. So problems we have, when I talk to governments, I'm actually giving a talk I'll get back to on Thursday evening in Toronto at the Walrus Magazine Forum. Well, young people don't even know what Walrus is. It's kind of, I think, a liberal New Yorker kind of for Canada, a kind of an essay magazine. And they have a leadership series every year. Margaret Atwood, they have Jean Chrétien, and they invited me to give a talk in Toronto on system problems in healthcare using cancer as an exemplar. So, it's hard to pick on one thing when we're advocating because the whole entire system is broken. I just broke my lower leg about 10 days ago. I just had surgery. I'm sitting up with a cast right now. But I've seen firsthand from the patient side how the limitations of everything, lack of family doctors, delays in diagnosis. Dr. Stewart reminded me the number of specialists in Canada, the shortage is worse per capita than the GP shortage, doesn't get any attention. Diagnostic imaging problems. The PMH, actually the head of cardiac imaging at UHN, spoke about this nationally a few days ago on CBC. We all know we have trouble with biomarkers, drug access delays, human resources, staff in every discipline in cancer, infrastructure, clinic rooms. This is the problem we're facing that's been so daunting for us. So things were somewhat easier in the old days. Why I got into advocacy was probably because I worked for a couple of years in the States, in upstate New York, ECOG satellite of Albany Med. When I came out, I wanted to be a community oncologist. And I saw rapists and murderers in the jail wards getting better care than the guards because the criminals had Medicaid and the guards had crappy HMOs. And the disparities shocked me. When I came back to Canada, I started seeing disparities based on money and geography. It really made me very motivated. This patient was on the front page of the National Globe. We opened the first Bayshore clinic in my own private office, free parking. We didn't charge anything to get drugs that were not yet funded by government for our patients. But nowadays, going through media is not that successful. You get shuffled off to all the committees that Dave talked about. These are personal successes I've had in the old days, working with patient voices, patient groups, HEMONC, gyne-onc, lung, and advocacy, even through provincial ombudsmans, the senator in Newfoundland on one occasion. But that's become much harder now. So the drug access landscape has become more of a pass the buck. I think Dave showed this before, but in 2010, we were second from the bottom in the Western world for speed to access cancer drugs. On the right recently, we're still there. Look where Britain went from number 12 up to the top. So other countries that are spending less per capita than we are have improved, and we have not. I'm pushing too far ahead here, Ian. So we recently spoke to CPAC. Many oncologists have no idea what CPAC is. When Canada had no national strategy for cancer, they were criticized. The Harper government launched CPAC. And I'm a bit critical of them because they have these top priorities. You can see the ones I've highlighted: high quality care, sustainable world class. Well, we're not there. Diagnose and treat faster at an earlier stage. Well, they have made some inroads into screening, which I laud them for, but also eliminate barriers to getting the care they need. And they've not done that. We actually spoke to them recently. I was very disappointed. I've learned a lot about government and processes. People do care. I thought they didn't care before. They do care. But the politics and the money are insidiously kind of involved in the background. CPAC said that they had an idea before, and they used to do this, of having a provincial kind of a rubric of how long it took for provinces to implement things. And they stopped because, this is a federally funded but pan-provincial body, and their citizens, the provinces, didn't want that. They didn't want them to look bad in a comparative data analysis. So the metrics we need to advance are being kind of hidden from us. Bob has worked at CanCertainty. I learned a lot from their adventures going back to, I guess the peak was 2014 on the oral versus IV drug access issues. And we learned from them how the power of a joint voice, like 35, 36 patient groups together, could amplify the messages of the basic problems in the system. So that's where our group comes in. We have HEMONCs, gyne-oncs, solid tumor oncologists across the country. We're having some in Quebec joining shortly. We're now bilingual to amplify the basic themes and let the individual patient groups get into the nitty-gritty. Here's that landscape of the processes we have that's slowing everything down. One big problem for our delays is we're a federal, a conglomeration of 13 jurisdictions that have to all do things separately. And we're advocating really to coalesce things much more with more pan-provincial processes that we have to buy into. What time is reasonable? When I asked the deputy minister in Ontario, what was a reasonable time from evidence, let's say a guideline or FDA, to a funding decision, yes or no. He agreed 6 months. He did not even know himself that it was 2 years back in 2014. So we have to get that performance standard up to government. PCPA, as we know now, is having trouble. They try to guarantee having a decision within a certain time frame, and they're basically over double that time frame now to have a decision, yes or no. They've just launched an open forum for clinician and stakeholder feedback into their processes, and they generally don't seek stakeholder input. The deadline's coming up November 12th, and you and we are probably submitting to them. So problems and solutions, well, other countries are doing this. We have Project Orbis to have a conglomeration of countries work on their regulatory approval together. The Canada Drug Agency has tried to do their reviews in parallel now with Health Canada. So they've sped things up by about 6 months. The Canada Drug Agency has this thing called temporary listing agreements for rare diseases, and BCPA at the same time has PTAP, what I used to call a back door. They didn't like that. It's like a front door to get things in faster. But it's super niche. It gets great reviews with the media, but really it's for phase 2 drugs that have very promising evidence to allow for rapid review and approval. There's only 1 or 2 drugs that have gone through that, including a lymphoma drug, I think by AbbVie, which we really laud them for to show this process has worked effectively. But we have drugs that have level 1 evidence in phase 3 that are languishing and taking longer. So I think we need a more rapid approach across the board. So our processes are rigorous, very high quality, but they're very duplicative and wasteful. We have a limited pool of HTA expertise in the country. Provinces are dipping into the same pool. The steps have been bolted on over 20 years. They were much faster before. The previous head of PCPA said at Grand Rounds in Ottawa, no one would have ever designed a system this way. It's not fit for purpose. A preceding head of PCPA asked me at the water cooler, well, I understand, your concerns, but why are you always in a rush? Reflecting a really ignorant, perspective on why we're in a rush for cancer. At a CAPT meeting, Canadian Association of Population Therapeutics last year, the speaker said, it's not their job to worry about speed. Their job is rigor and process. And they were kind of right, but they didn't hear the concerns we had. So observations, I've touched on these. Our drug costs are at the high end despite our processes. Our processes are advisory at the end of the day. The provinces still have to make a decision legally. They are allowed to say yes, even if PCPA says no. And they try to brush that responsibility off. There's poor coordination, overall accountability, and there's still an immature method to incorporate real-world evidence that we can do very well in Canada. What about the rest of OECD? So I think I mentioned that we have Project Orbis involving all these countries to try to do things together. We also have HTA processes that are going together in different countries. Managed access programs in the UK, Germany, Italy have led to rapid implementation and access before the full regulatory and pricing reviews go through. I think I'll show you just a quick slide on Britain. So in Britain's system, and NICE is not perfect for everything as we know, but 85% of drugs that get immediate funding and access do make it through the regulatory process and continue to be accessible. 15% get turned down, and most of us could live with that. We need the rapid access. Dave touched on surrogate endpoints. This is one kind of general systemic barrier we're approaching from our group, DFS, PFS. I learned a lot from other countries at recent meetings. So, for DFS, some people don't care about that. World famous people like Ian Tannick at PMH, for an adjuvant trial, said they want OS, they don't care about DFS. And what they're saying is that it's okay to have your cancer metastasize, which means you're going to die for sure and be on treatment forever with symptoms. But as long as you're alive at the OS cutoff, they don't care. But DFS means death usually. Most recurrent events are incurable. PFS, at a recent international meeting, leaders from Scandinavia, I think Denmark and Norway, their HTA people said, we move beyond this. We don't care about the mathematical surrogacy, the exact concordance values of hazard ratios for PFS and OS. We don't want our patients' cancers to get worse, simple as that. And they have accepted that. Nicole Mittman at CDA acknowledged to me this is a concern. They're taking part in a global NICE-led group to reevaluate surrogate endpoints. 85% of cancer drugs recently in Canada have been approved on PFS. So we are making some headway, but those are still barriers. So this is the collaboration I mentioned going on globally, led by NICE. Canada was assigned assignment number 2 to review the published methods for validation of surrogate endpoints. So this should be coming out in the next year or so. So what about our clinician voice, the principles behind our group? We started as a group called PACT in 2014, led by Sunil Verma. Barb Molosky is well known to you, Parneet Chima, Denise Souliere. And we had a furtive launch, but it was a bit too complex and ambitious. And things started working when Peacoder launched, and kind of the need kind of went away. So today we have identified that the need is there again. We have so many publications that frankly get brushed off a lot by government, talking about the impact, lives lost, but they tend to get shuffled off until voters care. Here are some more publications I just throw up as examples. Voters do care, and I think the government is getting that now. But the voters are really overwhelmed with like forest fires, global warming, international war and peace right now, tariff battles, lack of GPs. So getting attention is the hardest part of our job right now, and that's one area we're kind of struggling. So this was the paper that Dr. Stewart talked about how do we assess value, how do we really put the dollar numbers into some perspective to make it make more sense. And this is our group. So we launched our group and had a publication I'll show you briefly about a year and a half ago, but we've distilled our messaging down to 3 key areas for punch: access to diagnostics, molecular and genetic testing, and speed of process to get drugs accessible, managed access programs like the UK. Those are our key tenets right now, and we're making some good headway. This is the publication that came out of our launch meeting. Stephanie was part of it. David Stewart was part of it. We have more people on board right now. I can show you some of them shortly. Yeah. But the key targets are performance standards, not individual drugs. We don't want to fight for this drug or that drug, and government people really understand that. That's how they function in government. Accountability, transparency of their processes, disparity, not just between provinces, but between rural, indigenous, other populations, not about key drugs. And it's meant to be a kind of a ragtag fleet, magnifying our voices together, including pharmacists and nurses now. We have a head of CANO, a vice lead of CANO, ex-head of CAFO that are part of our group. Some of the solutions, you may have heard of Doug Ford's FAST program. I don't know if we were part of this, but our publication came out fairly early. Just when my nephew was joining Doug Ford's PR team, I begged him to kind of show it to Doug and the Minister of Health. At the same time, of course, he lost his brother to cancer. This was a burning issue for them. And now they've agreed that for at least 9 pilot drugs per year for 3 years, they will immediately allow access to new drugs once they're gone through Project Orbis and Health Canada before all the other CDA and Peacoder processes are finalized. So this is something we are meeting with every government to try to say, look, you haven't joined on, but can you be official observers like you were when Peacoder first started to see if you will take part once we have a running start to this. So our structure and governance, just to make it very transparent. So this is our membership, including pharmacy and nursing I mentioned. These are our docs. The green are pending people. We have 3 from Quebec pending shortly, and the underlined bold are our steering committee. Our collaboration, we have pharma sponsors. We've adopted the ethics framework that CanCertainty has, and many patient groups have, perhaps your group as well, to keep them at arm's length. They don't have any input into individual fights that we pursue. Boundaries, so again, industry is not involved. They have no key influence. We have the corporate transparency and code of conduct. It's been very helpful to partner with CanCertainty. Our budget runs through their program at Kidney Cancer Canada, so we have an arm's length protection, and that's been very helpful. And also because a band of clinicians of every cancer type and a band of patients together have a particularly powerful joint voice together. So in the home run here, let's see, there we go. So what have we done so far? We only launched a few months ago. Tremendous media attention after our press release. I was on CBC National, CTV National, the Ottawa Citizen, Zoomer website and magazine with their AM affiliates, got lots of hits. In Saskatchewan, Dr. Meeta Mann is my co-chair. She's had media attention on TV and print media. And we've met with all these provincial leaders, including ministers of health, deputy ministers, leads of cancer agencies. I won't go through all of them. We're meeting with British Columbia on November 28th. We have a 2-hour meeting with them. What about with other outreach? The federal government, Dave and I talked to the previous chief of staff, the federal minister of health. We were met recently with Samir Khan, who's a very highly powerful clinician at Health Canada for drug policy. He's doing a preceptorship with me, and I hope with Dave coming up soon. We just got our PR department's clearance on that. He wants to see at ground level what problems we're actually having. We presented to Health Canada at the CDA meeting at their office in Ottawa on surrogate endpoints back in April. We spoke with CPAC at 2 forums to share our concerns. I've reached out to CAMO to coordinate their advocacy efforts with ours. We've spoken at CANO and CAFO. JOPT is the gang of all drug companies making cancer drugs. I spoke at one of their meetings. We're collaborating with Barry Stein and his group, with CanCertainty, obviously. And very importantly, we have a good collaboration now with the Canadian Cancer Society. As you know, they have a very trusted voice by government and media, and they're attending most of our meetings as active participants and observers. We met just last week with the Canadian Medical Association. They're very on board. They spent an hour giving us very useful suggestions on how to collect metrics together, because right now they're very interested in equity, and we can connect with them. I spoke at a CAMO meeting. We also spoke at the HTA International meeting in Argentina. Bob was part of that with me. CAPT, the Walrus Forum, is coming up Thursday night in Toronto, and the Longwoods Forum on Health Policy. I'm presenting it shortly. So we're facing this reality where groups like Common Sense Oncology are saying OS or nothing. I have a lot of respect for the work they've done, to be honest. I mean, they do demand rigor and quality of data before wide adoption based on marginal endpoints, but we have to kind of keep them in check and sort of say, look, this is not the whole story, and where is it unreasonable? So that's kind of a kind of a whirlwind summary of what we've done. I think I'd say we've been surprisingly effective. We've had a lot of active listening from government. They've actually given us all their personal emails, and we're continuing our engagement with them. So if other clinicians involved with lung cancer want to join us, just email me, Sehdev@mac.com, and we're happy to get our voice even broader. But I'll stop there.
Thank you, Dr. Sehdev. You just did a great job of bringing that front line into focus and showing how coordinated clinician advocacy can cut through policy barriers and translate delays into real patient impact. And hopefully we'll continue to see decisions moving faster in the future to improve outcomes. Next, I'm pleased to welcome Eva Villaba. Eva will shift us from problem diagnosis to solutions, highlighting how value-based healthcare and innovative provincial reform models, especially from Quebec, can sustain access, reduce inequities, and accelerate patient access to precision treatments. Eva Villaba is the executive director of the Quebec Cancer Coalition. She's been working in patient advocacy since 2008, and she brings a deep expertise in health policy and healthcare management, grounded by an MBA and a Master's of Science in Health Transformation. She's an internationally recognized expert in value-based healthcare, and she champions learning, health systems, strategic partnerships, and co-construction with and for patients. Eva, welcome.
Thank you so much, Stephanie, and thank you to Lung Cancer Canada for having me as well. Talk about my favorite topic, value-based healthcare. I would say that value-based healthcare it's a paradigm shift. It's a philosophy. And when you talk about solutions, I would say potential solutions. I think I got into value-based healthcare in 2019 when I realized that everything that we're advocating for, most of the issues that we were fighting for can be addressed through a value-based approach. And so I started, and I became the first Canadian to get my master's degree in value-based healthcare. For those that don't know the Quebec Cancer Coalition, we're a nonprofit coalition of over 75 nonprofits in oncology, of which Lung Cancer Canada is a great active member as well. And our mission is really to improve public policy for people affected by cancer. So why did we get into value-based healthcare is because you'll see why. It's really, we go beyond patient centricity and really, how to make the system truly care about the patient. Is you can't improve what you don't measure. And so it's really about thinking what do we want from our healthcare system? Today, what we want is lowest cost, highest volume, without regard to what's actually happening. And I think that Dr. Stewart's presentation about really the impact of all of those delays that really hits that home. Like, if we're still serving all these people, but we're doing it too late, are we still doing the right thing? And so value-based healthcare, I'm going to talk about, how potential value-based healthcare solutions can actually improve access issues. But before getting into that, not everyone is maybe as familiar with what is value-based healthcare. So you might have seen this equation, which is value, because, is thrown around a lot as a buzzword. So what does value really mean? It's not pharmacoeconomic value. It's not, added value that you learn when you do an MBA. It's really value from the perspective of patients is value for the system, first of all. So that's a huge paradigm shift. Obviously, one that patient advocates could get behind, but I would argue clinicians, health system managers, even industry can really see the value of improving outcomes that matter to patients. So, I loved the two presentations before me really showed how overall survival is not really what patients want, okay? Living longer in pain is not really what they want. Do they want every single, service under the sun? Does anybody want a colonoscopy that they don't need or a surgery on the wrong leg? No, not really. But today, if, Sandy just got a surgery on his leg, what if they had operated on the wrong leg? Would the surgeon still get paid? Yes. Would the hospital still get paid? Yes. Would there be any consequences? And so a value-based approach really ties the reimbursement or the funding to outcomes. And that's a big paradigm shift. It's actually making the system more accountable, more transparent, and it's really defining value based on outcomes, which, is incredible that we haven't done it so far. So I'll go a little bit further, but basically, the idea, the denominator is really outcomes that matter. So that's clinical outcomes, yes. There's process metrics like delays that are important, but also patient-reported outcomes and patient-reported experience. That is also weighing heavily on this nominator of the equation. And in the denominator, and I think this is what's been holding us back so far when we're talking about access, is costs, not at one point in time, not of one test or one drug, but over the whole trajectory of care. And so when you have this longer term view of how much things actually cost when you do the right thing, it really changes the way you perceive costs and the way you prioritize your resources. Also, at this denominator of costs, you can also think of it in our public healthcare system. If people were a bit hesitant to use this notion of cost because, we don't pay the hospitals. But we can also think about it as getting an improvement of health outcomes for patients relative to the limited resources that we have to accomplish that. So that could be human resources, that could be money, that could be access to, surgery, operating rooms, et cetera. And so really the goals are to maximize patient outcomes, to focus not on volume, but on value, and to measure the outcomes, but really, and the cost per patient over the whole trajectory of care, which is it's a big paradigm shift. That's not how we do things today. So you can think about it in three ways. Today, we think of our systems as incredibly fragmented. I think every system in the world, can agree that health is way too fragmented. And so there's three core principles they're not usually said this way, but I feel that when I explain it like this, it makes sense to people. In order to have value-based healthcare, we need to have more integrated care. So we need care to follow the patient. So that means integration of the care team, not just at the hospital, but the before and the after and the during. So patient care is more integrated, more personalized. We focus on how to actually measure outcomes and use that information to improve the care pathway and to improve the healthcare journey for patients. We need data to follow the patient. So we need data integration. And we know that with the Pan-Canadian Health Data Strategy in Quebec, we have a new health data law. This is an essential part of actually enabling value-based healthcare. We need the data to follow the patient, whether they be at the community pharmacy, at the hospital, in a rehab center, in a long-term care facility. The data following the patient allows us to make better decisions. And that's where the HTA and the access piece comes in, because we need to actually have comprehensive, standardized data to make better choices. So for the clinicians to make better choices with the patients about their treatment, and for decision makers, including HTA, to make better decisions on what really works. So here's where the RWE and RWD piece really comes in. And it's starting, but we're really in early days. And I think we need to continue pushing this much more forward. So it does enable this informed decision that we want, and it promotes better health outcomes. And then finally, and Canada is lagging behind, but we're getting there in some jurisdictions, which is that the money follows the patient. So that means that today, like the example that I gave about operating on the wrong leg, the money is given in a more historical way. It's not necessarily, we don't want to promote fee for service either, because that actually promotes a more volume-based incentives instead of value. What we want is to actually create a financial incentive to create value, to improve outcomes, and to better use limited resources, while not, penalizing people that can't get the outcomes because they don't have the resources to accomplish that. So why does it matter? Why do you keep hearing about value-based healthcare everywhere? Well, we're going to talk a little bit about the HCA and access applications, but there's a big part that has to do with how we fund our healthcare system. What do we actually want to incentivize? Do we just want, everybody gets an MRI, or do we want the people that need the MRI get to have it as quickly as possible? And I'm sorry, I just got distracted by the chat. It's not for me. So we want the money to be able to incentivize better outcomes for patients, and so that requires a paradigm shift. And value-based procurement is one of the tools that we use, but there's also value-based payments, which in other countries, what they do is they better understand how much a trajectory should cost. They establish a threshold for what are the outcomes that we're aiming for, what are the best outcomes for this type of patient, and then you get a bundled payment. I won't go too much into the detail, but that's a whole other conversation. But value-based payments are something that work really well in countries that have been implementing value-based healthcare for over 10 years, including the Scandinavian countries and the Netherlands, with which I work a lot. Healthcare transformation, that's where we're talking about really working differently, integrating care into integrated practice units, for example. In Quebec, we have several hospitals now that are deploying this at scale, including the Jewish General Hospital, the CHUM, and the CHU de Quebec. And so they're really working differently, going beyond, simply multidisciplinary, interdisciplinary teams towards teams that are looking to improve outcomes and costs for the whole trajectory in real time. Industry transformation, I think we're seeing that many pharma companies and medtech companies are starting to really understand that value-based healthcare is one of the ways forward. And finally, precision medicine, and I'll get back to this, but the reason I really got into, I'm sorry, I just realized I hadn't advanced my slide. The reason I got into value-based healthcare is because I realized that we needed access to precision medicine, but that our system wasn't really made to enable precision medicine. With a value-based approach, you really, you create an environment where value-based healthcare, where precision medicine is really more welcome. I'll skip this because I see I'm running out of time, but so basically the impact is, if you're tying outcomes to costs, then and Dr. Sehdev talked about it, but we really need to promote the use of real world evidence where there's uncertainty. And I believe that with precision medicine, there is naturally uncertainty. Anytime you have something that's a little more rare, when you have subgroups of subgroups of subgroups, you're going to have some clinical uncertainty. Dr. Stewart talked about how the standard of care is moving so rapidly. And in precision medicine, the standard of care for everyone is maybe not what I should have as a standard of care for my specific, genetic mutation, for example. And so I think that by improving aligning funding with the real world evidence, we can and outcomes, we can really measure what the true costs are. And the reason that it's much more equitable is because a value-based approach actually promotes measuring outcomes and costs for every patient, not just some, not just the ones that you think might participate, but really each and every patient. And so you get to react. You have an obligation to actually improve the trajectory for each and every person that you're serving. And so that's much more equitable compared to what we have now. And so, we've touched briefly on the different funding mechanisms that exist right now. And I think that the main message here is that value-based healthcare aligns healthcare funding and reforms with patient outcomes for real-world value. We do have some examples that have been mentioned today. So there's Ontario's FAST program. There's the national pathways that we have with CDA's TLR and PCPA's TPA process. We also have some interesting demonstration projects. None of those apply to Quebec, for example. But I think what's really interesting is we have, for example, conditional reimbursements for rare disease. That's an example of, tying real-world evidence collection to reimbursement. We have an outcome-based agreements group right now that's doing a demonstration project. It's multi-stakeholder, including the government. We're trying to come up with a framework, and we've built on what has already been done by the Institute of Healthcare Economics in Alberta and the 20 Cents OBA Working Group. And what's really interesting is there's this need to tie reimbursement, especially in rare conditions, of which precision medicine and cell and gene therapy are very good candidates for outcome-based agreements. And there's more of an appetite for that. It's working really well in Europe right now. And that's another tool of value-based healthcare is outcome-based agreements. And then finally, there's a lot happening on the value-based procurement side, which, in Europe, they have used that model for medtech and for drugs as well. So these are just some examples of the Montreal in Vivo and the 20 Cents group publications. And then finally, I would just end with, why precision medicine needs VBHC. The regular paradigm, I don't have to tell you, you already know how slow it is. It's a one-size-fits-all, sequential lines of treatment, tumor-specific approach, high cost for low-volume treatments, and it's a really short-term vision. I mean, all HTA right now is a very short-term vision. When we're looking at, can we afford this? We're looking at the one financial year, and it's very hospital-centric. And so the more value-based approach for this is to actually think, okay, the right treatment at the right person, for the right person at the right time, I would add in the right location and with the right professional. Is it always the doctor? Not everywhere. And it might make more sense to question that. The value of diagnostic testing is actually included in that denominator of the value-based healthcare equation. We're looking at, the test looks expensive, but how much is the test and the right treatment versus giving 1, 2, 3, 4, 5 lines of treatment that don't work? And so there's really a value-based kind of argument for precision medicine that in today's paradigm, all they're looking at is how much it costs, not what you're getting for it. So this encourages a more pan-tumor approach. It really shows the value of targeted therapies. Again, that long-term approach, but also the significant improvement of health outcomes. It has a much longer-term vision, and it views the whole system. It has a more whole system view of the trajectory. Sorry. Okay. So in conclusion, value-based healthcare is a huge paradigm shift. But it's happening already. It's literally happening coast to coast, from the Maritimes, Quebec, Ontario, Alberta. The Saskatchewan government is taking a very serious look at value-based healthcare, and BC as well. The only one I haven't heard of is Manitoba. But otherwise, every other province is really looking very seriously at it. So is CDA, so is INES. The others we'll see, but it's really shifting the paradigm to make your decisions based on this value creation as we've defined, and systematic measurement of patient outcomes, experience, and long-term research utilization. So really looking at, if we give this person the right treatment, the right test, what does that save us? Can they be treated at home? Can they be treated at a community pharmacy? Is it going to cost the taxpayer less if we do the right thing at the right time for the right person with the right professional and in the right location? And this approach also influences how HTAs can do their evaluation. I can confirm to you that CDA and ENES are seriously looking at value-based approaches. We still got to get them to actually, move on it, but they're more and more open. And definitely when it comes to conditional approvals and collection of real world evidence, they're moving on that. They see, and we're pushing them as patient advocates to really look at some of those managed entry agreements where you give access now, collect data, and then readjust, reevaluate. That's something that there's more and more openness to that, and we keep pushing on that. That's a very value-based approach as well. And so we need this philosophy to guide our funding and resource allocations decisions. I recently met with the Minister of Health, the Federal Minister of Health's office. And this is something that they're, more and more open to. And then innovative funding models and health system financing reforms, like Dr. Sehdev talked about, the TLR and PTAP and even the FAST program, which is amazing. We're leveraging that to put pressure on other provinces like Quebec, for example. And it's working. It's a good start. It's not as, it doesn't go as far as we would like, but we really do want to start somewhere and then keep improving based on data. And then finally, I think we have to start thinking longer term and looking at the long-term effects, the whole trajectory of the patient, the whole patient trajectory, and not just one time. I think that's shifting. We need to move past these electoral cycles, for funding. But I do think that we're getting there. And what I'm happy about today is that we're having several perspectives, and we're all working in the same direction. So I'm very optimistic that we'll get there together. So thank you.
Thank you, Eva, for translating how value-based care can really manifest its way into practical pathways. I think that innovative value-based healthcare models truly do have the potential to sustain access and reduce inequities and really move our patients to precision treatments faster. Now I'm pleased to welcome Bob Bick. Bob is a health policy consultant with deep experience in public affairs, government and payer relations, and patient advocacy. He's advised industry, patient groups, clinicians, and researchers. He previously served as a senior consultant with Icon Oxford Outcomes and brings a decade of public sector experience, including as the executive officer for economic and labor policy in Ontario's Cabinet Office. He's a charter board member of Kidney Cancer Canada and the co-lead and co-founder of the CanCertainty Coalition, which is an alliance of 35 cancer organizations working to improve access to treatments across Canada. Today, Bob will examine how rigid funding algorithms and outdated reimbursement models prolong time to patient, and how advocacy-driven reforms, drawing on CanCertainty's multi-stakeholder successes, can harmonize access across provinces and accelerate equitable uptake of lung cancer therapies. Bob, over to you.
Well, thank you very much, Stephanie, and thank you, for, Lung Cancer Canada, for having me on today. I will not have direct control of my slides, so you'll be hearing me asking Lung Cancer Canada to advance my slides as we go around. So if we could go to the next slide, please. So I'm here today to talk about, in the larger sort of topic area of delays in access to cancer drugs. We've heard a lot of the reasons why there are delays, but I'm going to talk a little bit today about how there's some unique access problems and delays in access for drugs for rare subtypes of cancer. So as we all know, the evolution of lung cancer classification now includes various subsets that significantly affect disease management. And there are new targeted therapies and sequencing approaches that are being developed based on these driver mutations, allowing for more personalized treatment. But for rare mutations, I'm going to argue that our current health technology assessment processes are not fit for purpose. Next slide, please. So There's a lot of access challenges for these rare subtypes, but research and evidence supporting new treatment approaches for rare molecular drivers often come late in an exclusivity period for specific drugs. What I mean by exclusivity period is when a drug is ending its patent protection period. And when you combine that with a potential eligible patient population for some rare subtypes that are quite small, we have a situation where there's a lack of incentive for the manufacturers to seek reimbursement for some of these rare subtypes. And, you know, then the challenge shifts to other access mechanisms. Next slide, please. So what are those other mechanisms? Like I said, there's the typical mechanism for accessing a treatment is when a manufacturer has a drug indicated for a particular disease or subset of the disease. And it's a very onerous process. When a manufacturer is no longer incented to do that, there is a couple of other pathways, and that includes what's called a tumor group submission. That's a group of doctors from a specific province can work and do a submission to Canada's Health Technology Assessment Agency. Or there's a smaller group called the Formulary Management Expert Committee, but they have very limited capacity. But so there is a couple pathways, but they're not ideal. They're very there's a very heavy lift, and often the resources just aren't there to do it. Next slide, please. So I'm going to specifically here talk about one challenge that Lung Cancer Canada is currently working with. I'm working right now actually with Dr. Dave Stewart and Dr. Stephanie Snow on this particular issue. ALK-positive non-small cell lung cancer, it affects about 3 to 7% of non-small cell lung cancer patient population. There's quite a few treatments that have been onboarded for this particular subset, but the funding algorithm that is currently in place that has been put forward by Canada's Health Technology Assessment Authority is very, very rigid. Next slide, please. So what is concluded, and so a lot of the physicians that work with Lung Cancer Canada on their medical advisory board have participated in developing a sort of a clinical guidance on how to use these drugs. The guidance, this consensus guideline, does not at all match what is being funded in Canada. So they've come to the conclusion that more options and flexibility are needed in the sequencing of these first and second line treatments of these ALK-targeted drugs. But right now, the opportunity to fund them isn't there because of the previously mentioned problems in how to change the funding for these drugs. Next slide, please. So how do we secure the needed flexibility? Well, as I've discussed, the existing reimbursement pathways are very impractical or unavailable for achieving the needed flexibility. So Lung Cancer Canada now has to pursue another pathway. Now, the general access pathway is to go on a province-by-province basis, leveraging emerging evidence and effectively using the power of advocacy to convince provinces to fund different sequencing of these drugs. Next slide, please. So how do we do this? Well, the first thing we want to do is have evidence from a credible source. So there is a product line at Canada's Drug Agency, the HTA agency that I mentioned, that will quickly identify and appraise and summarize existing evidence on sequencing. So we're going to, Lung Cancer Canada, through their medical advisory board, is going to be appealing to that group through the appropriate mechanisms to try to get them to do a rapid review. Now, assuming that rapid review comes to the appropriate evidence-based conclusions that there's definitely a need for better sequencing options for this subtype, then LCC, Lung Cancer Canada, can then, equipped with this rapid review evidence package, go with its medical advisory board, engage provincial decision makers directly to try to change this access and improve the treatment for this small population. Next slide, please. But now we're going to shift from a particular advocacy case to why should it be this way. So next slide, please. What we've uncovered when we've worked on drugs for rare subtypes of a cancer is that the pathways in place just are not suitable. The incentives aren't there for the manufacturer to pursue funding, and the other pathways are onerous and resource heavy to do this. So there should be a better way. So currently, Cancer Drug Agency develops funding algorithms that determine the place of therapy of a cancer treatment on public drug plan formularies. It indicates how a new therapy can be used compared to the existing funded treatments, and it is intended to support provincial decision making. But they're an implementation tool and are not meant to assess new evidence, and therein lies some of the problem. Next slide, please. So what we really need to do is, while we're concurrently working, on this particular access issue to improve flexibility options for treating ALK-positive non-small cell lung cancer, we also have to try to change policy so that not every every patient group or every a doctors across the country don't have to continually try to find a new pathway or leverage very awkward pathways to improve treatment options. So what we need to do is improve the algorithm process, and particularly as it applies to small subtypes of cancers. And I'm going to focus on number 4 here on this slide, that the Cancer Drug Agency needs to construct an algorithm process to provide for new sequencing variations with evidence without requiring new drug submissions, so that we don't have to go on a case-by-case basis through these onerous pathways anymore. So right now, like I said, if you're fall into one of these categories of having a very rare subtype of a lung cancer, you could be waiting a long time to access your drugs. There's a specific fix that needs to be put in place. And so along with trying to improve flexibility on this one particular case, we also have to concurrently work to change policy in Canada so that we don't continually have to do this very difficult, lengthy, arduous process. Thank you very much.
Thank you, Bob. You just did a great job of clearly outlining how some of these rigid funding algorithms and outdated reimbursement models really do prolong that time to patient, and how advocacy-driven reforms like CanCertainty's multi-stakeholder approach can harmonize access across provinces. Now we're going to transition into an important segment of today's session, a panel discussion. And this is going to allow us to delve deeper into the themes we've explored and hear from each one of our panelists in dialogue. So I'm going to start off with an open question for all of the panelists. Taking no more than a minute, how would you describe what you think is the single biggest delay from regulatory decision to a patient's first dose? And what one lever could we realistically remove that could lead to a reduction of 30 days from that step within the next year? Why don't we start with Dave? What are your thoughts on that?
Well, I think that Sandy had mentioned about the situations in Britain and other countries, that there is immediate access or very, very rapid access once there is approval of the drug. And we very much need to do that here. Just that far too many patients die while it's going through all these evaluations, where eventually it's going to get funded anyway, but it may take months or years to get funded, and too many patients die. And also just to get the approval faster, again, he mentioned Project Orbis, and either Canada needs to join officially the EMA, the European Medicine Agency, so an approval there is an approval in Canada, or it needs to, Orbis has to apply to all cancer drugs. So as soon as the FDA approves it, Canada approves it. It takes far too long, not just because Health Canada does a reasonable job, but if drug companies do not apply to Health Canada until long after they've applied to Europe and the United States, then it just takes too long. So we need to move everything up to make it happen much faster.
Thanks. Sandy, what would you pick? One lever. Dave actually had several there, and they were all great ideas. But if you could pick out one.
As I mentioned before, it's so hard to pick one because everything is
Yeah.
broken right now. But I've been impressed by what I've learned from Bob, and I don't want to steal Bob's thunder, but about how the implementation phase is so indefensibly protracted. So what that means is when PCPA says yes, negotiates a price, it's 44 days to first dose in Quebec, I think in about 300 in other provinces. The provinces have agreed in principle to this pan-provincial process called PCPA. They've signed up. So they've signed up, they should have a pan-provincial agreement that when they've signed up, there's access right away. Like that's just a game, right? And it's not just them trying to buy time to avoid money, it's because they're inefficient and they just can't do it. So I think making them, hold up to the performance standards to say, now that you've got this, work on implementation and planning, assuming it's going to get funded, because most of them do, and not have any delay out the gate after you get a price. That would also save time quite a bit.
Yeah, I think that's where my money might be too, with the delays that come along with the negotiation. Eva, your perspective. Anything from unique from Quebec?
Very controversial. Yeah, it's controversial topic. I mean, ideally, I would like to see something like in the UK and Europe where you just give access right away to patients, figure out the pricing later. Like right now, patients are being held hostage. But here's my controversial proposal. Very controversial coming from Quebec. I would say have all of the HTA be done at a CDA, and Ines can continue to do some of the other stuff that they do, which is not HTA. Super controversial, I know. But if we want to save time, right now we're having an issue with Ines taking longer than CDA, and so it's actually delaying the negotiations, pan Canadian with PCPA, and so that's an unnecessary delay that if we were just to centralize, but I mean, there's so many political reasons why that's not going to happen in the short term. So I do think that each province is actually shortening. And I like what Doug Ford has done, because that's actually putting pressure on each province to hurry up and list and negotiate and accelerate what they can do. So I think if everybody kind of puts their rolls up their sleeves, including pharmaceutical companies that could do a better job of like accelerating some things, giving the HCA some visibility about what's coming next so that they can prepare and the resources, because that's another thing that's been slowing people down is like Ines had a resource shortage, and that really delayed the process. If they would have known what was coming, I feel like they could have prepared better. So maybe that was too many answers, but I think we all have many wish lists, many things on our wish list.
Absolutely. And Bob, what's your take on this? If you could fix one part of the system, what do you think would have the biggest impact quickly?
Well, I'm going to expound a little bit on what Sandy had just mentioned, and that is the lengthy time of implementation. And I'll give a couple of policy levers that should be pulled in order to address that. So, as Sandy mentioned, there's a wide variation from province to province of how long it takes to implement a drug after a successful negotiation has taken place at the Pan-Canadian Pharmaceutical Alliance. Now, the reason there's such a diversity there is that some provinces, or I should say one province, particularly Quebec, starts working on implementation issues immediately after health technology assessment has rendered a recommendation. Now, maybe it's a bit easier in Quebec because the agency, they're more tightly integrated in Quebec. It's one province. But really what's happening in Ontario, for instance, which takes 242 days compared to 44 days for average implementation of a cancer drug, is Ontario is waiting until the conclusion of the actual negotiation from the Pan-Canadian Pharmaceutical Alliance before they start considering how they're going to implement that drug in Ontario to make it accessible to patients. The simple policy solution here is start working on implementation issues immediately after the Canada's Drug Agency has issued a recommendation. That is going to cut many months. You mentioned like how about saving 30 days? That could save up to half a year. The delta between Quebec and Ontario is a half a year difference in implementation average implementation time. Start immediately. The excuse that Ontario has used is that what if the drug does not complete its negotiation? That's a very small number. That does not excuse this start of implementation. And I would also say one other implementation or one other policy lever that should be worked on is collaboration. All provinces are going to have some common issues with implementing certain drugs, whether it's CAR T therapy, which has got some very high complexities implementation. Why aren't they working on this together at a common level? Maybe at the Canadian Association of Provincial Drug Agencies, or CAPCA, I think it's called. Why aren't they working on this together? Coming up with a working group that identifies the major challenges to implementation and starts solving them while negotiation is taking place. That's, I think, where we have a real opportunity to compress the timelines.
Thank you, Bob. So, I mean, keeping along with that theme, Dr. Stewart, we do know that when we have to make changes that require new legislation, that really does take a long time. So, which are the process features in which you think we could most effectively start to save the most days? Will it be parallel steps, rolling updates, public service or standard timelines? Where do you think we could have the biggest impact? Because there's so many different areas we can attack.
Yeah, so essentially, for example, the HTA process, I said before, I think it takes far too long. to do it. I mean, I could sit down with a calculator and calculate all that stuff out in 15 minutes, and it'll come out very close to what they calculate. And I don't think that CDA needs to take months and months and months to do this. And if they want to take months and months, they should be starting on it at the same time the drug goes to Health Canada for approval, because it's probably going to get approved by Health Canada. So it should start right then and there.
Thanks. Sandy, with your experience with some of those great success stories that you've had in individual cases, if we're thinking as a clinician group who wants to start to putting together a clinician submission, what do you think are the most effective and need to have components in terms of, do we need to have real world outcomes included, case series, wait time impact? What do you think that's really going to speak to those HTA bodies and governments so they'll listen and we can see some more rapid changes or uptakes?
It's been a bit easy. I've been more involved in the breast cancer group, and the recent drugs have been pretty much slam dunks. So it's not been so difficult. But to the effectiveness that we've copied from Lung Cancer Canada, having the Breast Cancer Canada Real Coalition, having a framework for us to coalesce our thoughts in 2-week timelines, upload our joint opinions, that's been very effective. But I think the patient voice is critical, and making sure the patient voice, if you're working with a patient group, also understands some of the nuances of the medical definitions. Like, one drug initially was refused because they said that the benefit in PFS was not commensurate with patient values. Patients in that day, back in 2016, 2017, didn't understand PFS. When they understood it, they said, of course it's important. We want our cancer control longer, defer chemotherapy. So making sure we have that collaboration in place to do the submissions effectively and jointly together, collaboratively and efficiently. But we've actually copied a lot from your model in Lung Cancer Canada.
Absolutely. The patient voice. One patient's story sometimes is worth pages and pages of our statistics. And
Well,
so,
we recently hired not Doug Ford, George Smitherman, the previous quite cantankerous Minister of Health from Ontario, as a consultant. And he said the patient voices, even if it's not to the media, even if it's to the minister, like for cystic fibrosis, it moved the needle very quickly because they had been refused many times. And once the patient voice came out, the whole public was in an uproar. So those old strategies, what I call them sniper attacks through media and things, they're not the ideal way to make policy, but making the patient story foremost is still critically important.
great. You were talking about the importance of generating real world evidence and really collecting real outcomes. If, for instance, if we go into an outcome based assessment in part of value-based healthcare approaches, we do know that sometimes there's certain groups that are more difficult to capture impact. For instance, those that live in more rural areas, lower income populations, indigenous populations. Do you have any recommendations how to make sure that the true evidence that we're developing is reflective of all populations, not just the ones who are keen and like, oh, interview me, interview me?
Yeah. Well, it's really important that we standardize the collection so that everybody gets included and not just, so it's not like a clinical trial where you invite people to participate and you kind of pre-select with your own biases who's going to participate. If every single non-small cell lung cancer patient has to have not 25 outcomes measured, but like the 3 most important ones. You make sure that you measure the outcomes that are important to clinicians, yes, but also to patients. So what is important to patients? I mean, there are international outcome sets, for example, with ICHOM, the International Consortium of Health Outcomes Measurement, and they do have one in lung cancer. We're actually doing a value-based healthcare demonstration project in cancer in Quebec. And so how do you reach these people that usually don't get counted? You do it for everyone. You don't do it for some. So I think that's what's going to be key. And then one thing that we've learned from, you've all probably heard of the disaster that's happening with the doctors in Quebec right now and the government. The reason it's not working well is because they've decided to tie some indicators to their performance and their financing, but they didn't bother co-creating those indicators. So to answer your question, those indicate like which indicators should be measured. They should actually ask clinicians, patients, and then the managers or whatever, what are the outcomes that matter? And then make sure that actually fits as well with HTA bodies. So coming up with not 25, but five max indicators that make sense for everyone, and then measure those systematically for everyone. That's how you have more equitable access.
Thank you. Bob, a topic that's near and dear to both of our hearts is the lack of a standard way that take-home cancer drugs are funded in Canada. And so we certainly see disparities between jurisdictions. We are in cancer agencies in the West. If it's a cancer drug and there's a prescription, it's covered. But in eastern provinces, including the province in which I work in Nova Scotia, unless you're older than 65 and you're on the government program or you have a really good private drug plan, there can be a difference between two patients I see back to back in clinic. One is getting a targeted therapy because, their husband works for the Navy and they've got a great drug plan. The other one does not, so they're getting IV docetaxel. And this is something that I think it would be very important to really addressing this equity question. Do you have any thoughts on how we might be able to address this and get unity and address this disparity across Canada in terms of take-home cancer therapies and the amount of the cost burden that falls to patients?
Sure. I mean, as you pointed out, Western Canada, they typically come with a system approach where they don't differentiate where a person takes the drug or how a drug enters the body. If it's a cancer drug, it's a cancer drug, and the drug agency funds it, regardless of whether it gets infused in a hospital or whether you take it in a pill on your own sofa at home. When you get to Ontario and Atlantic Canada, I'm skipping over Quebec because Quebec has a different model, a mandatory drug insurance model, which is quite effective for dealing in pseudo equity, I'll call it. But Ontario and Atlantic Canada, the drug systems have evolved around a pharmaceutical program. So it used to be all, you remember the days, Stephanie, when most cancer treatments were infused in a hospital. And that worked out fine. But then with the evolution of new technologies where there were targeted treatments taken at home, those drugs fell under the pharmaceutical program. And then we were successful, as you recall, some years ago in Nova Scotia in convincing the government to build a funding program to cover that some of the costs for patients that fell between the cracks under 65. But that was a bolt-on program that is kind of poorly designed, not well understood. And that is very symbolic of how Ontario and all the other larger provinces have done them. They keep on bolting on new problems that are highly inefficient, difficult to run, and require more bureaucrats to run. In fact, you're probably familiar with the whole emergence of a new bureaucracy called drug access navigators. Every hospital in Ontario now has drug access navigators because the system to access cancer drugs, or many drugs, period, is such a Byzantine, it's a maze that it requires people, Sherpas, to guide you through the system. We have to start tearing down some of these reimbursement systems and rebuilding them from the ground up, because it's not just causing problems to access to patients, it's causing headaches for doctors. Doctors, in Atlantic Canada and Ontario have to order drugs through different systems. Dr. Sehdev can talk about how poor the system is in Ontario for ordering these take-home cancer drugs. It's called the Sehdev system, and it causes many hours more of administration for doctors, and it causes delays in access to treatment. So Dr. David Stewart will tell you again about how those delays are resulting in poor outcomes. We have to tear down some of these systems and rebuild them. We keep on adding these really awkward additions to these programs, and they make no sense anymore. They're costing the government money. They're causing poor outcomes for patients. They're causing more work for doctors.
Thank you. And I'd really like to thank all of our panel members today for their thoughtful participation in today's forum on treatment access and drug approval processes. I think there's been a really rigorous, solutions-oriented conversation. Together, we examined where time is lost after diagnosis across regulatory review, HTA, pricing negotiations, funding algorithms, and provincial implementation, and how those delays translate into missed windows for effective treatment and unequal access across Canada, and ultimately translate into life years lost for our cancer patients. I think there's a number of key takeaways from today. I think that we've heard that we need clear, harmonized timelines from approval to listing. We need more parallel and coordinated pathways across regulators, HTA, pricing, and provinces. We need time-limited conditional funding with real-world evidence to enable earlier access and access to therapies that otherwise our patients would never have access to. And finally, we need modernization of funding criteria and algorithms so that they keep pace with our biomarker-driven care and don't unintentionally deepen those inequities, especially for take-home cancer drugs. The message is clear. Precision medicine only will fulfill its promise to all our patients when evidence becomes access consistently, quickly, and fairly. Achieving this requires shared responsibility across healthcare agencies, provinces, industries, advocates, and people with lived experience. That's exactly why Lung Cancer Canada exists. As Canada's only charity focused exclusively on lung cancer, we convene voices, surface practical fixes, and push for the policy challenges that patients and families deserve. To healthcare professionals, please keep pressing for guideline-aligned funding that matches real-world clinical need. Share case examples where criteria and sequencing create unsafe delays. These stories and data help drive adjustments to pathways and listings. To regulators, HTA bodies, and payers, please expand parallel scientific advice and reviews. Set public service standards for key milestones and adopt conditional funding with real-world evidence to shorten time to patients while safeguarding value. To provincial cancer agencies, work toward pan-Canadian alignment on funding criteria for biomarker-defined populations, streamline implementation once national recommendations are issued, and close gaps for take-home cancer drugs so access is not determined by postal code. For our industry partners, please lean into value-based agreements and pragmatic evidence generation plans that enable earlier access and continuous learning, especially where unmet need and strong biological rationale exist. For our patients and caregivers, your experiences illuminate where systems stall. Share them. They help set priorities, refine criteria, and keep urgency at the center of reform. Our next step as Lung Cancer Canada will distill today's insights into clear, actionable recommendations and continue working with clinicians through our Medical Advisory Committee, including our clinician submissions, and with system partners to move these solutions forward. Thank you again for our panel members for your commitment and candor. Together, we can shorten the time to patient, modernize access, and ensure Canadians receive the life-extending therapies they need quickly and fairly. I'd now like to take a moment to make a special thanks to the sponsors of today's policy forum. I also want to extend my heartfelt gratitude to all of the participants and our panelists and your commitment to improving lung cancer care. I also encourage all of you to stay engaged with Lung Cancer Canada. We are, again, the only national charity dedicated solely to lung cancer. Our special sponsors that I want to name today are Amgen, Boehringer Ingelheim, Daiichi Sankyo, Merck, Regeneron, AstraZeneca, Bristol Myers Squibb, Janssen, Pfizer, and Roche. I'd also like to extend an invitation to continue to join us for the next session of our 2025 Policy Forum series. We will then be talking about bridging the gap, precision medicine, and lung cancer diagnosis and treatment. And at this time, we'll be talking about collaborative strategies for reducing the delays. That will be on November the 18th at 2 p.m. EST. And of course, if you're not available at the time that any of these webinars and policy discussions are happening live, they will be available on the Lung Cancer Canada website as recordings. I'd also like to invite everybody to the Faces of Lung Cancer briefing. This is our annual event that happens during November, Lung Cancer Awareness Month, and this will this year be on November the 6th. So again, would love to see people out to really hear stories that unite us and change that moves us. And where are we today in Canada with our status on lung cancer? Finally, the Evening of Hope is another very important event during the Lung Cancer Awareness Month. This year it'll be Sunday, November the 23rd, and this is a very special evening when we celebrate survivorship and usher in a hopeful future. And we come together coast to coast, live together in groups in many major cities, but also with a very important engaged virtual population that is able to join to truly extend to our potential participants across Canada. So really hoping to see you for there. And finally, want to remind you that as of last year, we had the launch of our new updated comprehensive guide to lung cancer, which is available for a download for the website, or you can order it. And this is an excellent resource to share with patients, families, and colleagues. In closing, I leave you with this call. Together, we can bridge the gap, ensuring that every cancer patient with lung cancer in Canada has access to timely, equitable, and effective diagnostics and treatments that they not only need but deserve. Thank you all once again for being part of this critical dialogue and for everything you do to make a difference in the lives of those affected by lung cancer.